Thyroid storm is a rare but life-threatening hypermetabolic state, mostly seen in hyperthyroid patients, which may be triggered by acute illness, surgery, or radioiodine treatment of the hyperthyroidism. Although rare, thyroid storm can be fatal. Up to 30% mortality has been seen. It can occur in the intraoperative patient or postoperatively up to 24 hours. The clinical features of thyroid storm include nausea, vomiting, diarrhea, and jaundice under GI symptoms, altered consciousness, confusion, agitation, delirium, seizure, and even coma, and death under the central nervous system signs and symptoms. The most commonly seen problems in the cardiovascular system include sinus tachycardia, arrhythmia, and cardiac failure. Other common manifestations include hyperthermia, sweating, metabolic or respiratory acidosis. The acute illness that may trigger this thyroid storm includes severe infection, stroke, trauma, and diabetic ketoacidosis. Surgery, especially on the thyroid gland, may also trigger the thyroid storm, and iodine therapy, including the radioactive iodine or iodine-containing contrast dyes, may also trigger the thyroid storm in a previously hyperthyroid patient. Others include vigorous stimulation of the thyroid gland during an examination or any palpation of the thyroid gland, and ingestion of thyroid hormones can also cause this thyroid storm. Laboratory analysis is usually not useful as the thyroid function tests are not routinely available to emergency physician. However, electrocardiogram, chest X-ray, urine analysis, and blood culture are some useful tests. In most of the cases, leukocytosis, hyperglycemia, and increased transaminase and bilirubin levels are usually seen, and these tests and reports will help us to identify the causative or the trigger disease of thyroid storm. Since thyroid storm is a life-threatening disease or condition, our treatment has to be prompt as well as adequate. The management of thyroid storm consists of anti-thyroid drugs, beta blocker therapy, treatment of the precipitating cause, other supportive care, and intensive monitoring. Among the anti-thyroid drugs, propylthiouracil at a dose of 500 to 1000 mg, which is a loading dose, followed by 250 mg every 4 hours, is preferred. PTU may be given oral or through nasogastric tube or even per rectum. If propylthiouracil is not available, then methimazole at a dose of 30 mg every 12 hours can also be given. And 1 hour after the first dose of PTU, potassium iodide or sodium iodide, or Lugol's iodine, or iodate or iopanoic acid has to be given. After anti-thyroid medications, beta blockers like propranolol or esmolol has to be given. If propranolol is given, if the patient can take oral medication, then 60 to 80 milligram propranolol every 4 hours, or if the patient cannot take orally, then 2 milligram IV every 4 hours. If propranolol is not available or esmolol is preferred, then 0.5 milligram per kilogram of body weight IV bolus followed by 50 to 100 microgram per kg per minute infusion has to be given. Apart from these medications, supportive care include administration of hydrocortisone 300 mg IV bolus followed by 100 mg every 8 hours, cooling of the body temperature, oxygen administration, hemodialysis and plasmapheresis if the thyroid storm is refractory, and treatment of the precipitating cause like antibiotics for infection, digoxin for CCF, and correction of diabetic ketoacidosis. Last but not the least is intensive monitoring of the patient, preferably in the intensive care unit, is desirable. That is thyroid storm.